There you go. I think that should be okay. Right?
Is it a presenter view you have or the full screen view you have?
We have presenter, right?
Okay. Let me switch the screen.
You do the bottom one next to the scale to zoom in and out should be okay. Oh.
Why it keeps doing that?
There you go.
Is it the right screen now?
Yes, yes.
Okay.
You can use your arrows or your mouse.
And are we recording this meeting usually?
Yes, we are.
Okay. Hi, so jumping right onto the topic, welcome everyone. So my objectives for the talk today is we're going to look into the ILD or DPLD, interstitial lung disease or diffuse parenchymal lung disorders as an introduction, and what is the current classification that we clinically use. Then quickly switch gears to focus solely on IPF from the historic perspective standpoint, epidemiology, risk factors, clinical presentation, diagnostic approach. I will spend some extra time on diagnostic approach. Then few slides on natural history progression, new treatments available now, and very briefly on complications and some of the future directions. So interstitial lung disease, ILD, as referred to as a heterogeneous collection of more than 100 distinct lung disorders that are grouped together because of the shared clinical, radiographical, pathological features, sometimes also referred as diffuse parenchymal lung disorders. I somewhat like the DPLD terminology better because it also includes not only the interstitium, which can be disease, but this adjoining structures such as the capillary endothelium and the alveolar epithelium. So it makes sense to call it diffuse parenchymal lung disorder. This is the complex classification system, but this is probably the most widely used clinically. At least I use it in my clinic all the time. And the classic distinction we should know when we talk about etiology is etiology known and unknown. And if you focus on the right side of the screen, there are several etiology unknown diagnoses. Among them, idiopathic interstitial pneumonia and IPF is one of the big sections there. Now, this is kind of when I teach the medical student, it's kind of I'm trying to put my patient in each one of these boxes. So if I see patients with ILD or diffuse parenchymal lung disease, then I start asking necessary questions about the history, some of the physical exam findings, some of the lab findings, and try to put them into any particular one of this box if I can identify. And if I'm not identifying, then I quickly move towards etiology unknown and then start looking into whether the patient has IPF, which is one of the very common diagnoses among the ILD umbrella. Just one quick question. The following are the names that has used to describe idiopathic pulmonary fibrosis except. I think the choice is obvious. I don't think I'm or Dr. Zulfikar are yet that important. Probably Dr. Parker may have had some syndrome under his name. So the reason to keep this slide is that IPF is one of the historic diseases that we have in medicine, and it has been called with various different names. It has been called with lung cirrhosis, Hammond-Ridge syndrome, cryptogenic fibrosing alveolitis, which is often still used in Europe as the terminology. What is the historic perspective? As I mentioned, the 19th century, we started calling it a cirrhosis of the lung. Around 44, that century where that decade where the Hammond-Ridge syndrome, particularly for the acute diffuse interstitial fibrosis of the lung, was described based on the autopsy changes. And then there are subsequently years, people have identified different variants of Hammond-Ridge, not so much acute, sometimes subacute or chronic. And somewhat in the 60s, our understanding started evolving more when the cryptogenic fibrosing alveolitis was introduced in England. And that understanding kept improving as we started developing more safer approach for lung biopsies. And around that time frame, there was a first suggestion that how about we start using steroids to cut some of those inflammation we see. And the major credit goes to Lebo and Carrington to develop the terminologies, what we use currently for ILD. They focus mostly on histopathology, but many of those histopathological terminology has located into the radiographic presentations as well as the clinical presentations. Moving on, in 70s, National Heart, Lung, and Blood Institute endorsed the inflammatory theory And that's where it started, and which was similar to alveolitis by the European investigators. And that's where it started the all different bronchial lavage investigations from the lung and role of steroids. And then in 80s, we realized that that doesn't work. So the shift of gear happened. There was some form of alveolar epithelial injury, and which is followed by the aberrant repair mechanisms. And last 3 decades or 4 decades or more, now there has been a constant new development. Our understanding has evolved, and there is a refinement of classification criteria. The ATS, ERS mostly publishes every now and then some of the updates on the classification system. Coming back to IPF, their epidemiology, it's a worldwide disease, higher in North America and Europe. You can see the incidence. Still, it's as compared to asthma or other the common chronic lung disease, it's not as common, fortunately. However, it is a progressive fatal disease, and whatever the older study has told us that the median time to death from diagnosis about 2 to 3 years, or sometimes less than 5 years, is general understanding. The newer studies may come out that may change, that may reflect some of the impact of the antifibrotic therapy on the natural history of IPF. What are the risk factors? We know it's a disease of elderly and male predominant, which may have gradually started switching now as the smoking is highly prevalent in females as well. And you can see the prevalence of tobacco smoke in IPF can range up to 80%. Then odds ratio is 1.58, and there is a stronger dose-response relationship where more than 20 pack year, your odds ratio go higher for developing IPF. And there is improving understanding that the smoking can not only lead to emphysema, but it also leads to fibrotic kind of changes, and also contributes to many other lung pathology. So are they really a single individual disease that happens from the smoking, or based on the genetic and personal predisposition, the natural response that comes as a lung injury is different in different individual? Matter of fact, many of the studies have pointed out that those different injury patterns can be present simultaneously in the same host. Environmental, for a long time, there has been a lot of understanding and thought behind that IPF can be a disease of environmental exposures. Some of the exposures has been listed down here. And it also been associated, at least linked with some of the viral infection, which may trigger the alveolar epithelial injury and subsequent aberrant repair. This is also a growing area of interest by a lot of investigators. There is a strong familial genetic component into it. About 2% of IPF cases, early age of onset, and autosomal dominant inheritance has been observed. And many of the genes which has been identified, particularly that they deal with the surfactant functionality or the telomere length, and some of those post-defensive genes alteration, such as mucin 5B, has also been associated with development of IPF-like disease. Quickly, this is This is a complex slide. Won't spend too much time on these pathophysiology, but essentially on the left side, with the genetic susceptibility aging, some of the risk factors, there is a recurrent injury that happens to type 2 alveolar epithelium, and then which leads to sequence of events, particularly the first, there will be fibroblast activation and proliferation. Now, what contributes to the fibroblast, that is also active debate, how that comes from capillary endothelial, those pores, and then deposited into alveoli. But all those host of events that happens and cascade of the chemokines that leads to fibroblast recruitment and eventual transformation into the collagen deposing cells. And you can see the remodeling that happens is also aberrant. That's why it is a heterogeneous disease. Some areas will have a lot of disease, completely distorted lung, and some area will have a spared lung. One important thing that I want to point out that it works in an autocrine fashion. Means fibrosis invites more fibrosis. It's a repair mechanism, but it is such an aberrant, and that's why it becomes progressive and fatal disease. So leads to next question. A 72-year-old male is evaluated for non-productive cough and progressive worsening dyspnea on exertion during the past year. Has no history of dry eyes, dry mouth, Raynaud phenomenon, arthralgia, myalgia, arthritis. Has a 30-pack year of smoking. Quit about 15 years ago. Retired, worked as a car insurance adjuster, and reports no environmental exposures. On exam, vitals normal, oxygen saturation 95% on room air. Findings of the lung include late Velcro inspiratory crackles at bases. Bilateral clubbing is present. Remainder of exam is normal. Spirometry shows FVC of 82% predicted, FEV1 90% predicted. So they are both preserved, but the diffusion capacity is reduced at 65% predicted. The chest radiograph shows increase in the reticular markings in the lung bases. High resolution scan shows bilateral peripheral basal predominant septal line thickening with honeycombing at the bases. I have tried to include as many as buzzword that has been associated with diagnosis of IPF. And some of the other diagnoses are less likely because DIP you should have more on an active smoker. Hypersensitive pneumonitis is one of the big differential that we have with IPF diagnosis is but some of the classic features are absent, particularly the imaging features. The pulmonary LCH is again Langerhans histiocytosis is a classically smoking associated disease in active smoker, and the same with the respiratory bronchiolitis ILD. That is also smokers interstitial lung disease. Moving on to clinical presentation, as described in the question stem, it's a chronic insidious onset of symptoms, particularly dyspnea, which is nearly universal symptom. And many of the patients suffer from chronic debilitating cough, oftentimes not able to let them sleep well at night, which I find particularly difficult symptoms to control. The fatigue is also common. Bilateral basilar Velcro-like inspiratory crackles is a classic finding, classic teaching for the medical students for the ILD. Clubbing can happen about 20 to 30% of folks, and if they are severely hypoxemic, then acrocyanosis can develop. Physiological finding on the spirometry, the most common thing, along with the restrictive pattern, we like to see the low diffusion capacity. And if it's progressive enough, then the patient can have either resting or exertional dyspnea, hypoxemia and desaturations. And the chest radiograph on the inside picture here, you can see is increased reticular nodular markings, particularly at the bases and the peripheries of the lung. Next few slides, I want to focus on the diagnostic approach, which is relatively recent, published in 2018, which has been a good guidance for at least the clinician, because that kind of leads us to the right path, avoid unnecessary risky procedures. So moving on, so patient with a suspected to IPF, and then you start looking into potential causes and associated conditions. So try to put those patients into those boxes of the classifications if they can. If we are not able to identify any potential cause or associated condition, then we go down on the left side of the algorithm. The usual first test of choice is CT chest with HRCT, high resolution. So as I mentioned, it's a diagnosis of exclusion. That's the number one thing we should always remember. IPF is diagnosis of exclusion. What are the other diagnoses we should always try to exclude is a chronic hypersensitive pneumonitis, connective tissue disease associated interstitial lung disease. Some of them include rheumatoid arthritis, systemic sclerosis, idiopathic inflammatory myopathies, and Sjogren syndrome. Various drug-induced interstitial lung disorders, then pneumoconiosis, which we often see here in a higher prevalence pattern. That you can see I listed down here, and then a relatively newer addition to this exclusion list is idiopathic pneumonia of autoimmune feature. And I try as best my job as possible to rule out any of this, because the disease therapy is quite different for any of these conditions compared to IPF. And somewhat, if you put the patients in one of this category, their prognosis also is better than IPF. Moving on to next step, what is the HRCT pattern look like? And what the buzzword you should look for is a usual interstitial pneumonia or a UIP pattern. If that is there, then it's almost confirmatory for IPF. And then there are some of the other categories has been developed that I would like to spend some time on it. So what are there are 4 patterns that when particularly looking for IPF, we should make sure that we keep an eye on that. Try our best to sell possible to define them into any of these categories. Now, there is a marked variability that I see in adopting these guidelines and kind of use of HRCT as an interpretation, because some of the radiologists, particularly chest radiologists, are very in tune of reading the scans based on these definitions, but oftentimes it's just listed as a chronic interstitial marking on the scan that does not mean anything. So it becomes kind of clinicians' tedious job of looking carefully. Now, what are we looking in the UIP pattern? It's a subpleural and basal predominant distribution. It can be often heterogeneous, but this is a condition that it should be subpleural and basal predominant. And the classic buzzword that is associated with UIP is a honeycombing, with or without peripheral traction bronchiectasis or bronchioloctasis. Now, what's the difference between UIP and probable UIP? The same all things, except honeycombing is lacking in probable UIP. Now, indeterminate for UIP has some features of both, but they are indeterminate with not as certainty. So they can have subpleural basal predominance. Subtle reticulation may have a mild ground glass opacity, some distortion. They may call it early UIP pattern that may be now evolved as what we call interstitial lung abnormalities. And the CT features and distribution of lung fibrosis that does not suggest any specific etiology, then it's a truly indeterminate. Now, this becomes kind of a more research categories. And some of the things that I always point out to my fellows, that what are the alternate diagnoses that you would always like to exclude. If your CT shows predominant features of the cyst or mosaic attenuation, only ground glass is seen, there is a lot of nodularity you see or consolidation, then it's most likely not IPF pattern that you are seeing. And some of the other things are listed here. If you see a lot of pleural plaques, then think about asbestosis. If you see dilated esophagus, then think about systemic sclerosis or related connective tissue diseases. Some form of rheumatoid arthritis findings, such as distal clavicular erosions. If there is a lot of lymph node enlargement, then oftentimes sarcoid becomes the etiology. The pleural effusions is not common. Pleural thickening is not common. So that may suggest other alternative causes. So this is the slide shows the UIP from A to E, from the top part of the lung to the base part of the lung. You can see definitely apical to basal gradient, means less disease at the apex of the lung, more disease at the bases of the lung. It's a subpleural distribution. You can start seeing the honeycombing. There's arrows on the set number E, shows that stack of thick walled cystic structures. That's called honeycombing, just like beehives. And then in between, you can see some of the airways are stretched apart. So there's a traction bronchiectasis going on. So it has all 4 features for me to tell that as a UIP diagnosis. Probable UIP, I think the paper, the diagnostic guideline use these slides to define as a probable UIP, but which probably is a little misleading and confusing, because oftentimes you can get confused whether I'm seeing on the slide E is still a honeycombing or traction bronchiectasis. But here, all the features are there except the honeycombing. And that's why it went into calling probable UIP. Rather than not spending too much time on indeterminate for UIP, but you can see it's a somewhat subpleural basal predominance disease with tiny reticular changes are coming in, but not much traction bronchiectasis, or honeycombing obviously not there. That's why it went into indeterminate for UIP. So once you identify the patterns on the HRCT, and where would you take from there? So if, as I mentioned, from the UIP, your diagnosis path is pretty clear. You have almost diagnostic certainty that you don't need any further steps, but you call that patient has IPF. Any other like probable UIP, indeterminate or alternate diagnosis, this box suggests the multidisciplinary discussion. That is must. That often involves a radiologist, pulmonologist, sometimes rheumatologist, and pathologist if you have pathology available. But over there, the role is to look into more diagnostic approaches. One is BL and the other one is surgical lung biopsy. So I will quickly go over what is the evidence on that. This is a very busy slide, but just to keep an eye on what is the normal structure of a bronchoalveolar lavage. More than 85% it should have alveolar macrophages. Lymphocytes only makes for about 10 to 15% of cases, and then some of the other cells are in a less frequency. When you see neutrophilic cellular pattern predominant in the bronchoalveolar lavage, that points towards the IPF. If it's a more lymphocytic pattern that we see on the bronchoalveolar lavage, that points towards a chronic hypersensitive pneumonitis or other alternate etiology. That's the whole reason I wanted to keep this slide, to make sure that we have a good understanding of that. And what is the other role for the bronchoalveolar lavage is to rule out infections, rule out the eosinophilic pneumonias, and some of the alternate etiology, as I already described. Moving on to the next invasive intervention we offer is surgical lung biopsy. What is the current recommendation? When you have a HRCT pattern of UIP, don't offer them biopsy. That's, you have almost diagnostic certainty. But for all other patterns, there is a consideration for surgical lung biopsy based on your individual risk patient profile and good one-on-one discussion with the patients. Because yes, diagnostic yield is good. It's still often considered a gold standard for diagnosis of IPF. However, you can see the substantial rate of complications, including 1.7% risk of mortality. So it's a not minor operation or minor procedures that we offer to our patients. And keeping in mind, many of these patients are delayed diagnosed, elderly, have other comorbid conditions, and they may often be hypoxemic by the time of presenting to your clinic. So it's a very careful decision making that we have to offer either surgical lung biopsy or no surgical lung biopsy. And that's where, again, multiple discipline discussion will help. Now, what we want to see when we do the surgical lung biopsy, so these are some of the buzzwords I will point out. Temporal heterogeneity means it's a disease where it's not a uniform involvement. Some areas have bad lung changes like honeycombing with fibrosis and distortion, and then interspread with the normal lung tissue. It is again subpleural and paraseptal predominance. And on the right side picture here with the black arrowhead, what is pointing is it's a fibroblastic foci. That is the active fibroblast depositing the collagen into the interstitium. That's one of the classic buzzword that you see on a histopath, and you call it UIP or IPF. Now again, from the pattern perspective, even on the histopath, there are 4 patterns listed there. I would not go into detail because I often rely on my pathology colleague for that as well. But just for the completeness, I want to show that how complex it can get when you have somewhat indeterminate feature to really tell what diagnosis the patient has. And then comes the, as I mentioned, multiple disciplines come together and discussing. This may be one example when the new tower was building, sleep physician, the legend, the birding, and then nephrologists came together to decide the quality of the building. We have slightest idea. So looking at the HRCT pattern and the pathology patterns, they come up with this complex table where your patient, whether the patient fits the diagnostic criteria or not. But the simple teaching out of this is, if you see UIP either on the scan or on the pathology, then you are pretty much certain about calling the IPF as a diagnosis. Further away you go towards the alternate diagnosis, or here indeterminate alternate diagnosis, you can start seeing the red boxes coming in, whether the patient meets the IPF criteria or not. The next question, again a long question stem, is a 78-year-old woman is evaluated in the hospital for progressive dyspnea requiring increased oxygen. She's diagnosed with IPF 5 years ago. She was evaluated in the clinic 2 months ago. At the time, she required 5 liters per minute of supplemental oxygen at rest, and daily activities were limited to dressing and eating only, both which caused severe symptoms. Currently, despite broad-spectrum antibiotic, IV methylprednisolone, 1 gram daily for 5 days, she is in severe respiratory distress requiring high flow oxygen at 80%. She's alert, breathless, and understands her conditions and treatment options. Physical exam, you can see blood pressure 150/85, pulse rate 110, respiration is 36 per minute. Saturation is 88% on 80% high flow nasal cannula. There is a diffuse crackle. She's clinically having finding of pulmonary hypertension on cardiac enzymes, unchanged for 2 months. There is no edema on the legs or jugular venous distension. Chest radiograph is unchanged. Which one of the following is most appropriate management? So this question sets the stage for moving towards the discussing the treatment. But unfortunately for this lady, she has gone into what we call the end stage disease process. So the treatment option remains here is palliative care, mechanical ventilation on acute exacerbation of IPF is almost certainly that certificate for them. They usually never come off the mechanical ventilation. And all other options does not make any change in disease course at this stage. So natural history and prognosis, the median year from diagnosis, the median survival is less than 3 years. This data is a little bit old. And what are the risk factors? There are multiple risk factors people have looked into, the predictors of survival. One of the picture is shown here as the percent decline in FVC. But this slide shows the what are the different predictors of survival has been looked. Demographic, elderly the age, the male gender, the lower BMI, presence of concomitant emphysema, pulmonary hypertension, radiographic changes such as having a UIP pattern compared to other patterns, PFT changes such as declining in FVC more than 10%, similarly DLCO decline, total lung capacity decline over time, lower the 6-minute walk distance, pathology findings, and various biomarkers all have been associated with poor survival. What we thought initially as a natural disease of natural history of IPF is a kind of a slow, steady decline starting from early diagnosis or maybe asymptomatic phase, and then early diagnosis and then late disease. However, that's not seems to be the true. Rather, it's a very heterogeneous disease course. Some patients decline very precipitously, some are the very slow decliners, and some have intermittent relapses and a little bit stabilization, again relapses, a little bit stabilization. So it's a very heterogeneous disease process. So one template does not fit all. What is the therapeutic approach? As I briefly alluded, in the past, the IPF was thought to be results of unrelating or unremitting inflammation from adaptive immunity and lymphocyte driven. Why they thought? Because whenever a patient came in with acute symptoms and they did the bronchiolar lavage, it was lymphocytic predominant. So they thought, oh wow, this may be some part our immunity is over time working. And then the therapies were developed to target the inflammation very aggressively, such as corticosteroid and some of the cytotoxic agent. What we learned from that experience that they do not work, and a matter of fact increases the mortality from infectious complications. And this was the landmark trial, what we call Panther trial, which looked into prednisone, azathioprine, and N-acetylcysteine role in for the pulmonary fibrosis. And you can see it causes it increases death from even any causes, and it also increased death from any causes or hospitalization. So we stopped doing this madness. The various therapies has been evaluated for this therapeutic role in IPF. You can see that, and based on this guideline that is a little bit dated now, clinical practice guideline 2011. But you can see that multiple agents has been used, and then we know that some of them are potentially harmful, some of them are potentially ineffective therapy. And only thing that we know that may be having some impact on the disease course and disease modifying property is the antifibrotic therapies. Some of the agents listed here are still used for the pulmonary hypertension therapies. And why we know that? It's based on, this is a simplification of the initial the pathophysiology slide, but here when the lung injury happens to alveolar epithelium, leads to innate immune activation and polarization with a vascular leak, and then fibroblast recruitment, proliferation, activation, fibroblast differentiation. So those are the steps where the pirfenidone and nintedanib has the impact on. What are those two agents? Nintedanib is tyrosine kinase inhibitor, works on various growth factor receptors. It was studied for Impulses 1 and 2 trials. The inclusion criteria was for whoever FVC was more than 50%. They did include the lower DLCO patients, so they did have some higher severity patients. What it showed, it slowed the decline in the FVC by almost approximately 50%. And then Impulsive 2 trial shows there was a decrease in the time to first exacerbation with a hazard ratio of 0.32. What is pirfenidone? Mechanism of action is not entirely clear yet, but it is a combined anti-inflammatory, antioxidant, and antifibrotic properties. It has been studied in 4 randomized controlled trials before getting FDA approval. Those names are Capacity 1, 2, Japanese trial, and Ascend trials. We again show the very similar finding, about 50% decline, 50% decrease in decline in FVC. So FVC still declines on both patients, but patients who are just receiving placebo, they decline faster. And pirfenidone is the one agent which has been started showing some mortality benefit in pre-pooled analysis of all these trials. So this is what it shows as a cumulative effect. There is about a saving of 200 ml FVC in the patients per year if they are on any of this agent. And then Impulses 2 trial, as I mentioned, showed a decrease in the time to first exacerbation. With the interest of time, I will move on. But one thing to keep in mind, that both agents has shown to increase the abnormality in the liver function test. So that monitoring is required. And the side effect profile is, yes, it reserves some form of discussion with patient, but both are associated with a significant GI side effect, some skin changes, weight loss, the liver abnormality, as I mentioned, and then the nintedanib has a little bit more cardiovascular risk profile compared to pirfenidone. What is the dose? Here is a 150 milligram twice a day. That's how you start, whereas the pirfenidone is a staged dosing, and max dose is 801 milligram 3 times a day. This was the impact on the mortality. You can start seeing the pirfenidone has started showing some impact, positive impact on the mortality of IPF patient. What are the other supportive therapies we should focus on? So there was a studies that done on the bronchial lavage showed acid degradation products. And then the thought was propagated that the patients silently aspirates in the lung, and gastric acid induced the alveolar injury, which is still a prevalent thought. But what we know from the evidence that putting everyone on antacids does not help. It, a matter of fact, increases the complication risk. So it's been limited only to the symptomatic acid reflux patients. And sometimes I go a little extra step to investigate that further, not only rely on the symptoms, but I may offer them some gastric motility or gastric pH studies in order to determine whether they truly have acid reflux or not. What is the other form of supportive therapy? Supplemental oxygen, yes, it helps with the dyspnea, exertional dyspnea, and what is the recommendation is anything less than 88%, either resting, exertional, or nocturnal. We have a couple of folks who are predominantly working in the rehab world. I use it extensively for my patients with IPF. Many of those data are extrapolated from the COPD world, but my clinical experience is that a lot of patients find benefit from it. And some of the therapies that I want to control their cough. Interestingly, thalidomide has, in a very small trial, has been shown to reduce the cough and improve quality of life, but I don't think that drug is available in the United States. Only 1 or 2 slides on complications. One dreaded complication is what we call acute exacerbation of IPF, just like acute exacerbation of COPD. It is an acute clinical significant respiratory deterioration characterized by evidence of new widespread alveolar abnormality. The consensus treatment is the treat with the steroids. It's a weak recommendation and very low quality evidence. And some of the agents that has been listed to trigger the acute exacerbation in patients with IPF are infections, sometimes post-op, drug toxicity, new aspiration, things like that. Matter of fact, I have seen at occasions patients who underwent the surgical lung biopsy, they get admitted in hospital for acute exacerbation of IPF. This is the baseline. In this picture on the left, panel number A shows the baseline scan. You can see the traction bronchiectasis, honeycombing at the basis, subpleural peripheral disease. And then when they have acute exacerbation, it looks like more of ARDS looking or diffuse alveolar damage that you can see on the pathology picture here. What are the other complications they are prone to develop? Venous thromboembolism, very high index of suspicion is required. So earlier you diagnose, you can save someone's life with that. The lung cancer, the IPF is a risk factor for developing a lung cancer in the folks. So following the regular screening guidelines is helpful. Pulmonary hypertension has been shown to increase the mortality. Obviously, no specific therapy has been yet designed, but there is a lot of investigation, a lot of interest in the role of some of the pulmonary vasodilators in IPF complicated with the pulmonary hypertension. And last but not the least, the lung transplantation still remains in the IPF still remains one of the main reasons to offer lung transplantation in our patients. When to refer, it's the earlier the referral is better. Whenever you diagnose someone with a little bit of abnormal lung function, particularly FVC less than 80% and DLCO less than 40%, the earlier the better the referral is there. And then referral does not mean they're going to be actively listed for the transplantation. And one slide of the future direction. If you go to clinicaltrials.gov and put the buzzword IPF, there are almost 400 studies listed under the keywords of IPF. So you can see how extensively this disease is researched on. I anticipate that as the two disease-modifying antifibrotic therapy has been out there in the market for the clinical use, there are a lot more agents are in pipeline for all this. And you can see some of those. Concluding slide, IPF remains a chronic fibrosing interstitial pneumonia of poor prognosis and unknown cause. Progress in the understanding of IPF natural history has really helped us to understand it's a heterogeneous clinical course. We appreciate the acute exacerbation as a cause of death, as well as we try a different therapeutic targets now. And big focus is now on a disease-modifying treatment. Some of the clinical trials are overgoing on that. There's a lot of interest in look at the role of comorbidities in IPF because these population tend to suffer from higher burden of comorbidities. And what are the supportive therapy we can provide? And lastly, the lung transplantation. With that, I would welcome any questions that we have. I think I see some chat. Sorry, I'm recognizing some of the answers late here.
Thank you so much, Dr. Sangani. That was a really wonderful presentation. Very informative and a lot of information. Does anybody have any comments or questions? You can use raise hand or just speak.
No one's going to ask something. I have a question for Raul. Sorry, buddy.
Sure, no worries.
I haven't heard recently. What's the role of cryobiopsy? Has that changed at all?
So current, as per those diagnostic guidelines, they neither recommended or said against it.
Okay.
So what it left to the conclusion, I believe, is to be offered at the areas of, if you have areas of excellence in your local hospital, then you can offer it. There's definitely higher risk of bleeding and pneumothorax. Why such a reluctance in approaching the guideline on that is, I think there's still not standardized. The technique is still not standardized. They have started using some balloons with the procedures and all that, try to reduce the risk, then develop a model where you only approach one or two sites on the lung, not go everywhere. So that's where I think there's a reluctance. But I believe in next few years that may become a standard of care, particularly
It just seems like, these are, older patients. A lot of times they already have a lot of comorbidities, and putting them through an OR procedure is just a tough thing to do.
It is, yes. And oftentimes my always a struggle happens in the clinic when I see a patient who do not have classic UIP pattern on the
Right.
scan, but they have significant fibrotic burden on the lungs, including symptoms, including scan and the PFTs. And then I often struggle with the decision whether I have to send those patients to surgical lung biopsy to get diagnosed acceptably, because chronic HP, as you know, about 30 to 40% of the time, you don't have any exposure history available.
Right.
And still you can have chronic HP where the diagnosis, after the diagnosis, the treatment is often rely on the immunosuppression rather than antifibrotics. But antifibrotics are also coming into that area as well. Good to see you, Dr. Doha.
I have a question, and this is Allison.
Yes.
So with pulmonary rehabilitation, specifically for our COPD patients, education plays a very big role. Why patients need to take their inhalers, why they should be using their oxygen, how they can prevent exacerbations. What type of topics should we be addressing with our IPF patients that are participating in pulmonary rehab? Is there anything specific that we should make sure that we're covering?
I just use the standard template, Alison, in terms of if I notice their symptoms are prevalent despite they are compliant to their therapies, prescribed therapy. My main intention that I'm looking for providing rehab is, yes, a little bit better tolerance of their dyspnea, provide a little improved quality of life measures, some of the freedoms they like to do by themselves. If I can achieve that, and oftentimes patient finds benefit with that. So, and then overall, I think at least in our lab, the rehab, our trained specialists are very good in educating them about general aspects, some of the breathing exercise, nutrition aspects, some of the depression screening and all that. I think that overall mixture that really helps them. That's what my intention when I send them to pulmonary rehab.
Thank you.
I think you are mute.
Sorry about that. Quick question. So very interesting talk about IPF. I work primarily in the world of black lung. And my question is, is there such a thing as IPF in a coal miner, or by definition, if they have pulmonary fibrosis in a coal miner, is it always black lung? Given the definition you're using of IPF, that there's no other cause.
That is true. So currently, from the clinical practice guidelines standpoint, you should not, it's a diagnosis of exclusion. So if your predominant pattern is pointing towards the coal workers pneumoconiosis and the significant exposure history, then yes, you may want to put that patient into the that category rather than IPF. However, if you still do the biopsies on those patients, you will still see UIP pattern. So that does not mean that UIP is exclusive for IPF. UIP can be seen as in association with rheumatoid arthritis as well. Why the distinction happened, if I believe it, that's how it was. The reason was that the therapies were very different designed. I think that boundary is going to be a lot more blurred now as the invent of the antifibrotic, and they are being increasingly used for any progressive fibrosing interstitial lung diseases, which includes progressive fibrosis, massive progressive fibrosis, which Dr. Wiseman will be still here, and that's one of our areas of focus and the study in future. The similar data has been seen with, they studied the nintedanib for chronic, based on the inbuilt trial. So those patients, they have chronic hypersensitive pneumonitis, drug-induced disease, some of the coal worker diseases were there too, the connective tissue disorders, systemic sclerosis, all of that. If you define them, they're having a progressive fibrosis. Despite the standard therapy, you can start giving them antifibrotic. And that is, by the way, FDA approved now.
Okay, thank you very much.
And Dr. Sangani, I want to ask a question about what you just described in terms of using therapies more broadly than what they've been demonstrated to be beneficial for. But I also wanted to ask a question about Dr. Warren's, because I was thinking about that early on. Could you go back to your original sorting slide and what
let me see if is my screen is still shared, Elizabeth?
No, you can just reshare it, but you still have co-host capabilities.
Okay. Um,
Because it has to do with his question about whether, you know, the original sorting slide, which is a great, useful slide for those of us trying to get a grasp on the 100 or more etiologies for interstitial lung disease. You had it, you know, the first cut, I think, was known and unknown etiologies.
is this the one?
Yeah, that's it. So later on, and you don't have to go to it right now, but a few slides beyond this, you have a risk factors slide as well. Risk factors for,
Yes. Oh, wait, I'm going opposite.
yeah,
I think that one.
right. And so what my original question when you put this up was, since there are environmental risk factors and viral infection risk factors, especially the environmental risk factors, in the earlier slide, sorting slide, it looks as though the presence of some of these environmental risk factors would constitute alternative known etiologies. And in a way, that's what Dr. Wertz's question gets to as well. If somebody has one of these known etiologies, like many years of smoking, or silica and asbestos and coal dust exposure, the sorting slide would seem to put them in a known etiology category, but this suggests the co-occurrence of IPF and some of these known etiologies.
Yes, I think I believe that the alveolar injury that happens, whatever your risk factor is, if I think that's where the complete dichotomy is somewhat difficult to adopt, because clinically you have to design a diagnostic guidelines which helps the clinician and it was somewhat similar to like a checkbox medicine, if I can say so, because that's what it kind of guides you that, okay, my disease process is here and these are my investigations I want to offer. Yes, as a pulmonologist, we kind of tend to do a little extra job in going one step beyond. But if we say primary care doctor looking at some of these things, it has to be a little simplistic. Now, smoking, it always perplexed me why the smoking has been associated with many different diseases of the lung. But it's been always, we have always looked them into the separate boxes, like asthma or COPD. If you talk about smoking, then COPD, then in also the COPD, the emphysema type, then the fibrosis of like a smoking associated ILDs we have seen separately. But I do believe that they do happen as a kind of a spectrum of injuries. Now, one injury pattern may be predominant in one patient compared to other patient may have coexistence of both pathologies that can be seen.
Okay. I think a lot of this has just evolved over time. I mean, Dr. Parker used to get up at this lecture when we did it and would say he stated for 20 years that smoking did not cause interstitial lung disease. And then he was, eventually proven wrong. So, very humble guy, obviously. But
So is this an accurate summary for Dr. Wertz's question? Because at another point, another one of your slides that made total sense, you said that diagnosis depended on a combination of clinical, radiologic, and histopathologic factors, kind of putting those all together, so that trying to decide whether our patient with, say, complicated pneumoconiosis also has co-occurring IPF that might benefit from disease-modifying therapy is going to depend on that combination of clinical, radiologic, including HRCT, and histopathologic features.
Yes, I think that probably the area of interest will develop eventually. And as I see and foresee that a lot of these antifibrotic therapies being evaluated for different indications, which is based on the solid understanding at the animal model level, the fibrotic changes once it sets in the progress from fibroblast differentiations into myofibroblast and deposition of collagen is almost similar in all different disease processes, whatever the inciting event is.
But I think to summarize, I mean, at this point, you couldn't call that IPF, right? Because they have an etiology.
Clinically, yes, that's
Where
right.
this
That's
is going
right.
to be an important thing, though, what Raul mentioned is, there's broader use of these antifibrotic agents. So it's not just IPF patients that you can get on these now. It's, anyone with a progressive fibrosing disease.
Well, in some ways, that's my other question. Is that mainly driven by clinical science or by marketing and shareholder value?
I think so far reading at the literature, I feel like particularly talking about inbuilt trial, maybe there's a lot of interest in this. Maybe we should plan a second talk on this, going over the evidence on that. But the inbuilt trial, they looked at the two groups, whatever the etiology at the baseline, but they first did look at the group with a predominant UIP pattern, and the other group was a non-UIP pattern. And then they gave nintedanib. Response was there on both group, but the UIP patients, whoever had a UIP pattern as a baseline, whatever the actual clinical association is, they had a higher response.
Yeah, I think that my understanding of I'm not aware that they published. I know there are studies ongoing of following this in coal miners with PMF. I'm not aware that those have been published at this point.
No.
So right now we're kind of in a standby, is my understanding, as far as proof of clinical efficacy in that particular group. But it will certainly be a game changer if that happens.
Yes, actually, I may share that probably we are in advanced talk to designing a clinical trial here at our institute into that specific subgroup of the disease or the patient population. We'll keep you posted on that once it goes live, but that's been an active area of interest right now. And I think one trial in Australia is already ongoing.
One quick question. On your slide, one of the later diagnostic slides, you had an acronym which was where you were talking about doing additional tests to refine the diagnosis, and one of the acronyms was MDD. What did that stand for?
Multidisciplinary discussion.
Okay, great. Like we're having right now.
Actually, there's been a lot of literature coming into that direction, that MDD, role of MDD in ILD, if you look that up. So essentially all it means is like you get together some of the experts on radiology, pathology, clinical experts, and kind of sit together, review the case detail, particularly the challenging one, and then assign them. Matter of fact, most of the ILD clinics, they do that often, like once a week.
That's a really novel idea to get all the involved doctors to talk to each other.
Yes. It's almost similar like a tumor board, right? The tumor board for the lung cancers or the other cancers, what they do.
Thank you.
This is Allison again. I have one other question.
Yes.
I know that you said that it's the pooled data is starting to come out for the pirfenidone with the mortality benefit. Is there enough evidence at this point to consider switching patients that are on other disease-modifying medications to the pirfenidone?
I don't think so, Alison. I don't think there was ever a head-to-head trial done between two agents. And I don't think that's an intention, to be honest, because there are two main players right now, so to say, as part of the competition. So I would not think that would ever happen, that you will see head-to-head trial. But it makes clinical sense if, particularly, say, one of my patients is, I have several occasions, patients who has referred to me as a second or third opinion, where they have been tried on one agent, could not tolerate it or some side effects, then tried another agent, still had some trouble, and then they come to me. So it has been looked in that direction, that you may consider asking your patients to try a different agent if you do not see the projected response or they develop a lot of side effects. But I do not see that will ever happen, that they will have a head-to-head trial and this one is better than the other one, because when you look at the clinical trials, more or less designed on a very similar ground, and the effect was very similar to both agents.
Okay. Yeah, I was just wondering if the mortality benefit was enough to say maybe we should try the pirfenidone even though you're doing okay on the nintedanib.
So that is also from retrospective data, Alison. That is
Okay.
a pooled analysis of all the RCTs and some of the retrospective data. It's not as the one of the endpoint of the RCTs where they say, oh, we're going to look for mortality impact, because that requires much longer term design of a trial.
Right.
So I believe that when the further assessment will happen, then the median survival time will change. When a significant number of patients, matter of fact, I'm looking at my IPF cohort, only 20% of folks are using antifibrotic. So it still hasn't penetrated that well into the prescription stage. And also, I think cost, I did not mention that, but the cost is a big factor, particularly for our patient group. It's a very expensive medication. So they require a lot of support, either from pharmaceutical or good insurance support, things like that.
Yeah, I don't think I have any patients that are paying for their medications out of pocket. They've all gotten, luckily, some support from the companies. So.
Yes.
Thank you.
Thank you everyone so much. This has been a great discussion. We can always do a part 2 and continue this discussion probably for the next session, but we also have, for the announcement portion, July 5th, we're not going to be having a session due to the holiday. So the next time we'll meet is July 19th, and we're hoping to have some cases submitted. We could have that as a case type of session, or if we want to continue this discussion, that is fine too. If Dr. Sangani can, you won't be in, will you? My apologies, but we can continue this type of discussion or anything. If you have any topics in mind, please send them to myself or Mitra, and we'll be happy to do that since we have some time till that date. And I really appreciate everybody coming in today.
I think we should probably discuss the progressive fibrosing type and review some literature. I think there seems to be a lot of interest in that, and that also some of my areas of interest as well. So we can certainly think on that.
Absolutely. Thank you so much. Just send those in to us, and we'll be sure to try to update that with everybody. Thank you, everybody, for joining us today, and I hope you have a great week.
Thank you. Bye-bye.
Bye.